finally got a call from Connie Soto from the Heart Institute, and did she tell you the results of your test? No?
Even if she's, no, but you can tell my
Yeah,
dad.
the Trenzel stress test says he has a bad heart. So if we were gonna do anything, they'd need to have him seen by an interventional cardiologist, and then we have to do some more treatment on him before the heart is strong enough for him to have anesthesia. So having this surgery, like I said, the Roto-Rooter job where we look in your penis and scrape out some tissue, and then we send it off to see whether or not, well, I'm 99.9% certain this is cancer, prostate cancer, not just because of the blood test. Because we can't put you to sleep, I can't do those tests. I'd like to do a biopsy on his prostate. Usually we do that through the rectum, but what's usually in the rectum? Doo-doo, right? And if I was to put it in his bloodstream or in his body, that he could get really sick. And 1 out of every 40 healthy people gets sick like that. That's called sepsis. I know of one person who had a biopsy done, and 4 hours later he's in the ICU and he died in septic shock. So at his age, at 87, right?
87.
I don't want to put him through that kind of risk, especially since we can't put him to sleep. So the only thing I can do is have him seen by the interventional radiologist. Okay? These are the doctors that not only read x-rays, but they actually do all the procedures to put the tubes in. I'm talking about him getting stuck inside. They can get into the kidney, they can put a wire down past the blockage all the way in the bladder, and then they can slide a straw, we call it a stent. And they put it over the wire, and there's a curl in the kidney, it goes past the blockage and it curls in the bladder. That way the blockage will not block the kidney anymore, and the shishi can go in the bladder. He would also have to have a nephrostomy tube, because the CT scan shows that the prostate is so big and the cancer is so big it's blocking him and keeping him from emptying the bladder. If all they did was put the straw inside and he can't get the shishi out, he's going to leak out of his side forever. So I want the stent inside and the tube coming out of his back. I also wrote for a referral to Dr. Swati Arora, A-R-O-R-A, and I'll give you a copy of the notes so you can review it. And the ladies up front are going to help you get an urgent appointment with Dr. Arora, because since I can't do a tissue diagnosis, we want a medical doctor who's going to agree that the tests and all say 99.9% certainty this is prostate cancer.
Okay.
And she actually, as a medical cancer doctor, has a better possibility and probability of being able to get certain medicines and treatments authorized for him.
Okay.
Because we need to get him on something really quick, because otherwise...
I'd rather go through the back. I'd rather go through the front.
He said to go through the front you need anesthesia, and you're not well enough to get anesthesia.
Your heart is not good enough.
Yeah.
So it sounds like he would permanently have the tube then.
No.
It's just
No.
for the procedure.
It's to get the straw inside, and because he can't get the shishi out because of the cancer and the big prostate, we want the tube over here just to drain the kidney so this kidney stays open. You really need the best kidney function you can for any of the treatments that they'll have in the future, especially if he doesn't respond to hormone treatment. Remember, in breast cancer, right, in women, they give them hormone treatment, the anti-estrogens that can shrink the breast cancer. We have the same thing in urology. We can give anti-androgens that shrink prostate cancer. Well, if we shrink the tumor and shrink the prostate, and he starts shishiing better, then we can take this tube out. Okay?
So the tube he'll get the tube put in, and it'll be temporarily in.
It'll temporary until Dr. Aurora can get him on the right medicine, if she agrees that this is cancer, and she can try shrinking the prostate cancer.
Okay.
Okay?
And then, so for presently, like right now, he would still stay on his blood thinners until we...
Yeah.
Okay.
Okay, until you see the interventional radiology doctors. Yeah. And they don't have to put a big tube in, right? So
Okay.
again, the ladies up front are going to schedule with interventional radiology at Straub, and then you go talk to them, and they'll put the tube in, and they'll have their own recommendations about how long he has to be off the blood thinners.
Okay.
Right? Usually for about 2 or 3 days before, and then if they get the tube in and the urine clears up, then they can start back on the blood thinners again. But I'm not going to, pre-guess.
Yeah,
what they
no, I
do
understand
when they
that.
assist upon it.
Okay.
Yeah, this is not the best situation to be in, but, our hands are kind of tied because of the heart condition that he has.
So do you understand what he's
And
saying,
because
Dad?
of his age.
You need to go to know anything else?
Do
I'm
you?
not strong enough.
Your heart's not strong enough.
Yeah.
Do you understand, Mom? The problem is we get home and they don't remember anything.
Yeah. But that's why it's good that all three of you are here, right? And yes, it's good that she's here because she needs to help explain to him, but if she doesn't understand, that's why I want to give you the note, okay?
Yeah, notes would be excellent.
Where is this doctor?
She's down at the main Straub on King Street.
On King Street.
Now, unfortunately, she's leaving in December.
Oh.
But we have
She'll-
8 oncologists that will cover for her, and there's another one coming in this month. So if she can't see him, we'll have somebody. All cancer doctors cover all the cancers, but certain ones do a better job at certain special cancers. Yeah. So I'd like to get him to see Dr. Aurora first, if he can. If not, someone else can see him. But we're trying to get him in like this week.
Well, that'd be good.
It's that urgent.
Okay.
Okay.
Any questions, Dad?
Now the other thing is, are there any other males in your family? Do you have any
No,
brothers?
no,
Okay.
it's all girls.
Do you have sons?
Yes.
Okay. Even if grandpa had prostate cancer, there's genes and things that can be passed down. So your sons have to be start checking at the age of 40 instead of 50.
Okay.
Okay. Women also, if you have daughters or you have sisters, because some of the genes that are responsible for the more aggressive prostate cancers, and I would kind of consider this more aggressive. We don't know because we can't do a biopsy, but his PSA is actually not as high as we would expect with a regular cancer. It sounds kind of funny. The more aggressive cancers don't have the high PSA. They have a PSA that's a little bit high when it should be, instead of like it's like 13 in him. Normally when people come in and the cancer's already spread into the bladder, it'd be like in the hundreds.
Wow.
And so when it's low, but we know it's spreading, we know it's an aggressive type of cancer. Especially the genes like, is there any breast cancer in the family?
You had something.
Yeah, but your mom.
Yeah.
I'm talking about gene. So the BRCA1 and BRCA2 genes are actually associated with some of the more aggressive prostate cancers. So since Dad had prostate cancer, you actually should be aware that you might need to be screened more aggressively for breast cancer.
Okay.
I know it sounds kind of weird, but there is that
I'm a
association.
sister.
Okay.
Breast cancer.
His sister.
Yeah.
She
My
had
sister.
bone that they removed.
Yeah. I go for my map. They do those tomos and
But
the
even more so,
ultrasounds.
when your doctors should know that you have an aunt that has breast cancer, and your dad had prostate cancer. Again, could be the same gene.
Okay.
So you should actually be checked like at least every year.
Yeah, I go every.
Some
I
people
go
would
every
say
year.
even every 6 months. Okay.
Okay.
So let's get this straight again. Your blood tests are both high. I'm 99.9% certain that this is aggressive prostate cancer. You're on blood thinners and you have a weak heart, that the cardiologist will not be able to clear you for anesthesia and surgery. I don't want to just do a biopsy through your rectum, because if I gave you an infection from that biopsy, you could die. So the only thing we can do is to get you scheduled with the interventional radiology doctors to try and put the straw inside. And I'm insisting that they leave the tube outside as well, so the shishi can come out this way, until the oncology, the cancer doctors can treat your prostate cancer enough that you can shishi normally. Okay, so I do want both the straw and the nephrostomy tube coming out.
So he'll have a bladder bag then.
So he won't have a bladder bag. He'll have a bag coming out this way. Yeah.
But
On
like
the side.
a but
It's
like
a bag, yeah.
like a
It's-
pee bag. So do you understand that?
That's temporary.
It's temporary until hopefully the cancer doctors can get you on the right drugs to shrink this cancer. And then if they can shrink it enough that you can shishi better normally, and you're not holding on to shishi in the bladder, then they can take this one out. Okay, so when they say temporary, I'm not talking about 1 or 2 weeks. We're talking probably about closer to about maybe 3 to 6 months that he'll need that.
So you understand that you got your tube coming from your stomach, and then you're gonna also have a
Which stomach?
he has a peg tube.
Pain.
Yeah, okay, so yeah, he have a peg tube, but you'll have one coming from your side as well, the left side.
I don't know if you really gonna understand that. That's gonna stay in there just like how this one does for maybe 3 to 4 months. That might get like removed, but you'll have it for a while.
Yeah.
You understand? And there's gonna be special cleaning and care that's gonna be needed like for that.
Okay, and when you talk to Dr. Aurora, because of all this, you know, you may need to ask her, because again, they're better versed than the urologist. They can help you schedule for a visiting nurse,
Yeah.
you know, to just reassure them about the tubes, make sure it's being properly monitored and cared for. Okay? So,
Thank you.
let's go back over here. So Mr. Harold Misawa, I already put the orders in like this one, yeah? I'll sign this. So the ladies up front will try and get you an appointment with Dr. Aurora and with the radiologist to set
Okay.
this thing up, okay? And we should see him back hopefully in the next couple of weeks.
Back here.
Yeah.
Or
Unfortunately, I'm going to be going away in 3 weeks again, so it's going to be hopefully within the next 2 or 3 weeks, yeah?
okay.
And I'm going to say that you really have to have you get in to see Dr. Aurora as soon as possible. So this one is a 99 here, 99213. Okay. I went ahead and put all the note together, hadn't talked to Miss Soto, yeah?
Okay.
Spoken with cardiology. Who cannot clear patient for anesthesia. Okay. So I'm going to highlight this part. Okay, so we're going to take this part away here. Okay. Referral to interventional radiology. Or left. Antegrade means going from the top down. Retrograde means going from the bottom up, which is what I would do. But since we can't do anesthesia and all, we're going to go from the top down, okay? Antegrade, left JJ stent placement. And again, I'm saying I want the nephrostomy tube coming out the side because he can't empty his bladder all the way right now, right?
Mm-hmm.
So referral to interventional radiology here. Urgent referral. Dr. Swati Aurora.
Is that a male or female?
Female. Oncology. She's very good. We lost the best oncologist I've ever met, Dr. Ian Okazaki. He was actually voted twice. Doesn't happen
really?
often, right? Voted twice the best doctor in Hawaii.
Oh.
He moved to Minnesota about 8 months ago.
Wow.
But she came in, she's covering for him. We're trying to get her to permanently move here, but she has some obligations, so she's going to go back, and then hopefully she's going to come back here. Okay, but we'll have them seen by someone, right? Urgent referrals by your oncology. And then follow up in like 2 to 3 weeks, okay? Okay, so this will go to Dr. Matsukawa, Dr. Kamimoto, Dr. Tanoi, Dr. Marina Hisugi Levesque, I'm not sure who that is. This is Kali Soto, the cardiology APRN. And this will go to Dr. Swati Aurora.
And the girls will handle the referral and the 2 to 3 week follow up, yeah?
Yeah,
When we go up front.
right now,
Okay.
So, mainly this is really needs to go to Dr. Aurora, Dr. Matsukawa. Yeah.
Mm-hmm.
Okay, so we're gonna go. And who's his heart doctor?
Tanoi, which
Dr.
is
Michael
the
Tanoi. Okay.
which the APRN
Mhm.
is. I don't know,
And that
in the office. Yeah, that's
Okay, so let's go here, here, here. PCP. Soto.
Well, the PCP is Matsukawa,
Robert Matsukawa.
Oh, yeah. and then Soto is the cardio or APRN from cardiology.
Michael Tenoy,
Mm-hmm.
right? And then Dr. O'Rourke. Okay, so I'll have him printed out and we'll get him back in a couple weeks.
Okay.
But we'll work on getting him scheduled with the interventional radiologist and the oncologist now.
And then we're gonna go home with a summary of today.
Yeah.
Yeah. Thank you.
You have the old copy of the note. Okay, why don't you come up this way?
Thank you.